I don't know if we have the clinical picture, but this is the clinical picture of the same patient. So it's a pucker sign. And I think everyone, probably most of them, said that they're going to do a milking maneuver. And I think that's the correct thing. You don't need to manipulate or do anything, but just first reduce the pucker sign before you reduce the fracture. What this means is that there is an entrapment of the spike in the brachialis, and you need to first determine posteromedial versus posterolateral, and then the milking maneuver. And this is just a video of a milking maneuver of a similar patient, not the same patient, but you basically are just trying to grasp the brachialis and walk distally, and you will feel like a small pop, and then the pucker sign would disappear. So once you get the pucker off, then you do your maneuver to close reduce. In this case, we were not able to get the reduction, so this is what we did. And you just I do it percutaneously, but you can make a small nick. You go in the posterior aspect in the triceps in the midline, and you put your K-wire right into the fracture site. Now you can choose to use different instruments. You can use the Steinman pin, the blunt end of it, or maybe a freer elevator, or you can use a hemostat, something which you feel comfortable that you're not going to be damaging anything anteriorly. So you put this in the fracture site like we have done now, and you just go maybe up to half of it, not through, and then you try and lever it. So you can see how the K-wire is bending, and because you're levering the fragment, trying to get the fragment line up with the proximal part, and then you get the reduction. So if you can't get it reduced because it's shortened, then this is one way of reducing the fracture. It has worked well our rate of opening these fractures is very, very low. It's less than 1% that we would open a supracondylar. That's because you use these milking maneuvers, and you use the intrafocal pinning techniques and joysticking the fragments, and that works for most of the cases. And then we went and put our conventional wires, and then this is a 5-month follow-up on the patient. And the patient did well. And this is a radial neck, but I'm just showing the blunt instruments that you could use. This is a Steinman pin that is used to elevate the radial neck, and similarly you can use one of the freer elevators, something blunt you can use to get the fracture in position. So a lot of these fractures that you see in pediatrics, you can just use a safe path, blunt instrument, and can get the position fragment back into position without doing a formal opening. Thank you.